Welcome, everyone. I know people are continuing to join us, but being mindful of time, we're going to go ahead and get started as we have a lot to cover today. Welcome to the first of our 3 webinars on the series of Palliative Care in Practice, Strategies for Community Management and Referral Insights for Family Physicians, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Denise Campbell-Scherer. I'm a family physician in Edmonton, and I'm the Associate Dean of the Office of Lifelong Learning and Physician Learning Program. The office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. So I am a colonial settler from Nova Scotia, New Brunswick, and settled here in Treaty 6 territory in 2009. And we acknowledge today that we're coming to you from Treaty 6 territory, which is the traditional and ancestral territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as being part of the Métis homeland. We acknowledge the many First Nations, Métis, and Inuit who've lived in and cared for these lands for generations, and we're grateful to the traditional knowledge keepers and elders who've gone before us. We make this acknowledgement as an act of reconciliation and gratitude to those whose territories we reside on or are visiting. Please go back to the slide, Natasha. Thank you so much. So just in reflecting this week, we have provided a link here to the CMA, the Canadian Medical Association Apology to Indigenous Peoples. And, I really recommend that everyone consider spending some time to review it. It's incredibly powerful and impactful. And I think it's part of our ongoing objectives with the office to try to reflect on reconciliation and how we can integrate this important work into our day-to-day. Next slide, Natasha. So in terms of housekeeping for the webinar, there's a few items. I think at this point in the pandemic, we're all very familiar with Zoom, but if you have any questions about technical difficulties or L3 programs or services, please use the chat function for that. But if you have questions for the speakers, please use the Q&A button on the bottom of your screen. Please review what's already been asked and upvote any questions you'd really like to see answered. We cannot guarantee that the panelists will be able to respond to all of your questions. Next slide, please, Natasha. So we will send everyone who's registered a copy of the recording and a copy of the Pearls for Practice document with resources. As well, if you scan this code, it will take you to the My Lifelong Learning Plan, which is a way that you can get certified credit for completing professional development activities. As well, if you're a CFPC Main Pro Plus participant, you can do linking learning to practice to get credit for this. Next slide, please. So it's my great pleasure today to introduce my colleague and friend, Dr. Sarah Burton-MacLeod, who's going to be presenting our first session. These sessions have been in the works now for 4 years. There was a little detour of a pandemic that got in the way, so we're delighted that Sarah's going to be able to come today and provide us some practical clinical pearls on palliative care and address some topics such as pain management, dyspnea, and provide additional tips around getting a consult. And we'll also be sharing some resources for us. So just in terms about Sarah herself, she finished her medical school at Dalhousie University in Nova Scotia and then got kidnapped out west. She wanted to see more of the world, came to the University of Alberta to do family medicine residency in 2002. Her first rotation was emergency medicine at the Alex, so she knew right then and there she'd learn a lot. Following residency, she locumed briefly in both rural and urban family medicine before coming to complete additional training in palliative care. And since then, she's remained in the palliative care field full-time, but with increasing interest in medical education and in the areas of wellness and mentorship. She's currently the residency program director for adult palliative medicine and also works at the Office of Advocacy and Wellbeing at the Faculty of Medicine and Dentistry. So she enjoys antiquing, making pasta, browsing for new fashion finds online, coffee with friends, and travel adventures. And if you ever get a chance to talk to her, ask her about her experience with yurts. So thank you very much, everyone, for your time. And everyone, welcome to this great new webinar series. And thanks to the team who's been working to put this together.
Thank you so much for the kind introduction, Denise. That was just so lovely. And as you said, thank you. Also, I'll just say as I'm sharing my slides here, many thanks to the whole team that put this together. You know, like this is, as Denise said, being 4 years in the planning, and really glad to be at this point. So yes, so happy to be here with you all today. And if any of you are going to be watching this online afterwards, very happy that you can join us that way.
The screen we're seeing is your presenter screen.
Oh,
stop sharing and then just reshare, but just pick the one that's just the slides.
oh, I'm so sorry.
Don't
I'm
worry.
just going to stop sharing, and then I'm just going to reshare. Let me see now. Will this work?
Yes, that's perfect.
Oh, okay, brilliant. Okay, good. So then I actually wanted to start with a huge thank you, because I know that all of you in this audience are here because you have a heart for this work as well. And I also know that you and your colleagues are providing so much amazing palliative care already. I know I was in an email conversation with our colleagues, Dr. Simon and the group from the Calgary zone as well. So if any of you are calling in from that zone, we just all, both from this zone, that zone, all the zones in Alberta, just really want to say thank you, because truly we know the vital role you're playing in our system and caring for people with advanced illness, their families, and also bereavement care as well. So thank you. There are a couple things I wanted to touch on today. And as I say, I really wanted to make this as practical as possible. So they're kind of short snappers, but just picking sort of one or two elements from each, and I'll review some of the pearls of thought that hopefully will be helpful for you. The first would be about pain, and specifically around total pain and psychological distress and the role that can play. Then a bit about dyspnea, nausea, delirium, more specifically in the setting of advanced cancer. A bit about conversations, and just a few things that I found helpful that I've learned over the years and wish I had known before. And then a little bit more about our own well-being and supports as well. So to begin with, as I say, I wanted to talk a bit about total pain. I think it's probably something that you will have heard of. But when we talk about this concept of total pain and psychological distress that can impact both the pain experience for our patients, but also pain expression, how do we detect that? How do we manage that? What are some strategies is what I wanted to talk about today. And I also want to thank my colleague who's retired a few years ago now, Dr. Cheryl Nikolajchuk, who's a psychologist who worked at the Cross Cancer for many years, as well as on our tertiary unit. So the next few slides are hers that I use with her permission. But this is around that concept and the work that she and others have done around total pain and the psychological distress within the context of the pain experience is that inner state of suffering. So occasionally you may have even heard the term total suffering, which I think is also very apt. And I think that that reflects our patient's experience, unfortunately, in many ways. But it's not just, of course, the physical, but emotional, psychological, spiritual, as well as the practical factors as well that can, as mentioned, complicate both the pain experience and expression. So what are some things that you may look for if you're wondering whether this could be a factor in the patient's experience? And to say that because we're all whole people, right? I mean, our emotional, psychological, spiritual experience of any illness, and especially if it is life-limiting and very serious, as with our palliative patients, is always going to be impacted by these different factors. But the trick here is teasing out whether there may be a very important psychological component or existential, spiritual, emotional that is impacting the expression of pain that we're seeing as well. And the reason for that is that we don't want to be piling on opioids when that, in fact, is not really the solution, right? And if we're able to recognize when that is present, we're able to mobilize a team and get the proper supports, and I think be able to help our patients in a better way. So some of the things that we look for, there are things that are specific to the pain syndrome itself in terms of are the opioids effective or not? What is the pain intensity rated at? Is there a history of chronic pain and now acute pain on top of it? We also look at specifically patient-related factors. Often our young patients are more prone for understandable reasons. The unfairness of life cut short, young children at home potentially, financial issues being higher risk for this to occur. Perhaps our patients that are more socially isolated, and certainly those who feel a sense of spiritual disconnection can be very high risk for this. And definitely there are other factors that we'll look at too in terms of comorbidities, and in particular, not just overall mental health history, but certainly if there's a history of substance use disorder, then that again would potentially be a risk factor for patients to have this immense psychological distress impacting their experience and expression of pain. The other things we can look at that perhaps we can measure in a way would be things like the pain intensity score, and not uncommonly, you'll hear not just pain, but often many other symptoms rated 9 or 10 out of 10, and pain described as, quote, all over pain. Many breakthrough doses used, even if there's an around-the-clock regimen, and even if the baseline opioid is increased, you may find that that does not affect the number of breakthrough doses that is needed. So things like this can give us a bit of indication. And occasionally, we are even able to ask our patients, when you feel down or worried, does it affect your pain? Or we may hear from nursing staff that they notice that patients may be more prone to use extra breakthrough doses or opioids on a PRN basis if they're lonely, if they're upset, if their family's away, sometimes if their family's there, depending on the dynamics. Anyways, these are all things that we look for. And I guess I just mention it because hopefully, as I say, this is something practical for you. And I think the bottom line is we don't need our patients to necessarily have insight into this, but we do because we want to help them, right? And we really want to make sure that we're not treating psychological pain as physical pain, even though it can be expressed in that way. And that way, we're going to have to look for as many supports as we can for them, right? And I know sometimes on our tertiary palliative care unit, for sure, when I practice there, we have the luxury of an amazing interprofessional team that I know from very brief time in practice in family medicine that isn't always available everywhere. I'm aware of that. But I think, any spiritual leaders from the community that may be helpful, our colleagues from the interprofessional team, home care, often really great resource, and the teams there. And certainly if they have coverage, if they're able to get psychotherapy, that can make a huge difference. As well as non-medication related, non-pharmacologic techniques that I've listed here too. So essentially, this is one of the things I think of when I have a patient that I keep trying things and it's just not really working, and I find myself wondering, why are they not responding to this increase in medications, be it opioids or other things? Or why is it that we keep trying all these interventions and nothing seems to be working? Why are they often escalating doses, opioid toxic delirious, and then we have to switch and try something new again? If you're ever in that pattern, these are the things I think of. Is it total pain? Are we really missing something? And could they really benefit from that interprofessional team approach and more of that psychological, spiritual type of support that maybe we haven't recognized today? Now, it also depends whether they're ready and open to that. And I also grant you that it may not always be that either we have all the resources we want or that patients are ready or wanting that. So of course we have to work with them, but it's important for us to, I think, at least recognize. The second would be, are we missing something around the mechanism of pain? Perhaps there's a neuropathic feature to it that we just haven't recognized so far. Perhaps they need some adjuvants for that. Is there the possibility, if coping has been a challenge in the past, especially if there's a higher risk or history of substance use disorder, is there a potential possibility that patients have been using the opioid or the breakthrough doses to cope? And if that's so, then again, that's something we really need to recognize. Or is there underlying cognitive impairment, not necessarily delirium, but any cognitive impairment that, is also not making it as easy to get a full, true understanding of the patient's pain experience. So these are all the things that I generally think about to troubleshoot. The other piece I'll just mention, certainly acute on chronic pain I mentioned can be tricky. And I know that for many of you, you will have more chronic pain management experience than I do. But to say that a lot of times figuring out the baseline and setting really realistic goals has been really helpful. Because of course this is not uncommon in our patient population, and often potentially looking to titrate to their functional ability and other markers rather than the pain report has been also potentially helpful too. Don't forget that, you know, we've got our teams, but certainly I have called the chronic pain team here at the U, and they do have a telephone intake process. And I think certainly, you know, there's always experts in other fields that we can ask for help, right? Likewise, I've talked to my colleagues for my patients with substance use disorder, as well as serious illness, potentially malignancy or otherwise. I think in that situation too, if there are people, for example, from the Radius Clinic here in Edmonton, or anyone that the patient already trusts, who already knows the patient really well, these are amazing resource people, and also really great in terms of building trust with between yourself and the patient would be to try and work with those who already have their trust and know them the best. And so I may have spoken to you on the phone for that reason as well already. Generally speaking, longer acting agents, especially for opioids, are advised. But really, a lot of this is about being trauma informed and really just giving as much choice and agency to our patients as possible, and then working as hard as we can to build that trust, repair trust if needed, as we know it's sometimes lost in our system. And then again, potentially titrating to function as opposed to the pain rating scale, which is what we would usually recommend. But it depends on the situation. And certainly, again, caring for the whole person takes the whole team. So those are the main things that I would recommend for pain. Just be aware of that concept of total pain and the psychological distress that can impact pain expression. Team approach can definitely help in the situation of complex pain, some examples of which I just mentioned. And there are times where titrating to function may be a better marker than the pain rating scale, even though it's useful. And I always ask patients what they would rate their pain. If a patient is still rating their pain 9 out of 10, but they're able to go on weekend trips to the Rocky Mountains, then to me that's success. If some weeks prior they were bed bound. So I know that's a practical tip that hopefully you're already using, but just wanted to highlight it as being something a little different than perhaps the way we were all originally taught. Now, just a few notes on dyspnea here. I think for me, the main thing is just remembering that it's just subjective sensation, right? And as you know, it may or may not correlate with the amount of disease or the extent of disease or oxygen saturation or any other parameters that we would often look at. So if we look at that subjective report, again, you know, within the context of the illness overall, because certainly, as I mentioned with total pain, you can certainly have psychological distress in the setting of dyspnea that it layers on top of it as well. So just always bear it in mind for any symptom. But our main approach to dyspnea would just be to look at what are the underlying causes, what can we change, what can we treat, what can we reverse, and try to do that as much as we can. And then in terms of managing the symptoms, of course, we would tailor it to etiology. And I would say that there are definitely some considerations for oxygen, depending on what the etiology of the dyspnea is, and also for the role of corticosteroids, again, depending on the etiology. And I will mention that, of course, for more end-stage disease, especially if comfort is more the focus, that opioids are safe and effective. And we do have good evidence, even for those with CO2 retention. If you start low and go slow, right? Just as our colleagues in care of the elderly will tell us. And I try to always remember that. Just start to really use it judiciously. And the other thing I would just say is that I generally find that patients who experience dyspnea are often very anxious. Even if they have no prior history of anxiety or any anxiety disorders, they tell me that feeling short of breath makes you anxious. So again, with very end-stage disease, I will quite often look at an anti-anxiety agent. And because our patients are also so high risk for delirium, which I'll speak about in a moment, I would generally try to pick a neuroleptic over a benzodiazepine, unless they have very refractory end-stage dyspnea. At which point, again, if comfort is the goal, you've redressed goals of care, family knows what's happening, patient, if they're aware, also knows what's happening, then certainly for me, it's not a time to hold back, especially if you know that this is hours, maybe short days. And so in terms of neuroleptics that I may have been using before, one that I particularly like in very end stage illness would be methotrexate if it's available. It can be given subcutaneously as well as orally. And because it's kind of old school, right, and hits many different receptors, it is more sedating, but does tend to be particularly effective as an adjuvant, even at very low doses, like a 6.25 milligrams for patients in this stage. And certainly, again, if you know that this is very end stage and even that is not helping when you titrate it, then for sure this is a time when we would add in benzodiazepines as needed. So the clinical pearls I was thinking of for dyspnea was that A, it's subjective, B, that opioids can certainly be considered an end-stage illness, and that anxiolytics can be helpful adjuvants. So that was my quick topic on dyspnea. For nausea. So for nausea, again, honestly, it really depends on the underlying etiology. And again, we would look at what are some potential reversible causes. Anecdotally, most common cause of nausea for our patients I find is constipation, even for those not on opioids, but definitely more so if they are. And certainly there are lots of other etiology for our patients as well, particularly for cancer patients, hypercalcemia, malignancy, so treatable, you know, unless it's recurrent and refractory. And bowel obstruction are ones I always have on my radar. Certainly if there's any neurologic symptoms at all, I think of increased intracranial pressure. But yeah, so mostly then what we do is once we reverse what we can, if we still have a more chronic nausea underlying it, then that's where we try and think of, okay, what is the underlying etiology of this nausea and what receptors may be involved. And then of course, as usual, potential interactions, side effects, and cost are factors we look at as well. So you may have seen this one before, but just to say that, of course, vestibular causes of nausea are really not that common for our patients, especially with malignancy. But I just mentioned that because it's why we don't use gravel all that much. And again, increased intracranial pressure would be a little bit of a different scenario. And of course, there's lots of good strategies for that with corticosteroids and potential radiotherapy if they're not surgical candidates and so on. So then I would say most commonly, and I'm not sure if you can see my cursor here, but the point is that most commonly it would be the chemoreceptor trigger zone, and which sits right near the vomiting center and has a really thin blood-brain barrier. So I think of it as anything floating by can set that off. And also the vagal and sympathetic afferents from the visceral abdominal organs. Those are the two that are usually involved in any type of chronic nausea in our patients, especially advanced cancer, but I would say worthwhile thinking of for any of them. So because you have dopamine receptors for both, as well as serotonin receptors, that gives you a chance to actually use some really commonly available, really good antiepileptics. So unless there is a compelling reason, like increased risk of extrapyramidal side effects, for example, or underlying neurologic illness such as Parkinson's, Maxiran or metoclopramide is really great. And so you will probably hear us recommending that a fair amount, just because it will work in the chemoreceptor trigger zone as well as the gut. And in fact, if you were, of course, in a situation where you have progressive bowel obstruction, you wouldn't want that prokinetic effect of metoclopramide with complete bowel obstruction. So in that case, if you were at all concerned about that, haloperidol can actually give you a really nice dopamine blockade in the chemoreceptor trigger zone, and you can get rid of the metoclopramide altogether. Anyways, that's a slight sidebar, but metoclopramide is great most of the time, with few exceptions. And if there's anything oncology treatment related, so anything to do with chemotherapy, radiotherapy, and so forth, immunotherapy, we have better evidence there for ondansetron. So we will certainly look at using that. And then my third pearl would be anything in the terms of chronic nausea in the setting of advanced malignancy specifically, because there's so much inflammation around malignancy. I often will kind of have a corticosteroid, specifically dexamethasone often, as kind of my back pocket. If you really get stuck, a trial of this will often give the patient a bit of relief. So in terms of clinical pearls for nausea, I would always consider what pathways or receptors are most likely to be at play once you've reversed everything you can. And then specifically for advanced cancer, a trial of corticosteroid would really potentially be worthwhile in a lot of situations. Okay, so then we get to delirium. So I tried to think of the most practical things that I could think of for delirium. And I will tell you that still, most of the evidence that we have around the treatment of delirium in palliative care is mostly in the setting of advanced cancer. I will say that the more recent important articles on it in 2017 did start to include patients with serious advanced illness that was non-cancer related, but the majority still had malignancy. So for this topic, I would say this is really quite specific to advanced cancer as opposed to some of the other topics that I spoke about earlier. What can I tell you about delirium in the setting of advanced cancer? Well, it is extraordinarily frequent. And the studies that we did here in Edmonton showed somewhere around 28 to 48% of the time patients were presenting in a delirium to our acute palliative care unit. I've since read one out of MD Anderson and theirs was not dissimilar, but they had a bit better reversibility rates, possibly because ours are more end stage. And that's where the conundrum lies. So they say that in the last days and hours, upwards of 89% of patients will become delirious. And so then you're faced with the situation of, okay, this patient has both advanced cancer and delirium. Is this going to be reversible or not? The other piece is that, of course, delirium can often be missed, especially if it is hypoactive. And I always bear in mind that patients with hypoactive delirium can have extraordinarily disturbing perceptual disturbances still. And so I always make sure, if I'm at all suspicious of a delirium, to ask them about that, because it can really be profound suffering for them. Also, of course, delirium on dementia can be more subtle as well. And so years ago, 1990s, we actually did look at, were we missing patients with dementia on our palliative care unit? Sure enough, we were. And in fact, the nurses were a bit better than physicians at picking up on it. So again, it's reversibility. That's the tricky part. The other piece is that what we did find was that there are generally 3 precipitating factors. And so I'll often tell learners, if you found one precipitating factor for delirium in advanced cancer, great, keep looking, and then we also know that each episode of delirium, or as the disease progresses, it is then more likely to be irreversible with time. So your greatest likelihood of reversibility is earlier on the disease trajectory, but you may not always know where you are exactly on that disease trajectory when your patient presents. So for that reason, yes, of course, you do the usual workup and try and look at all the precipitating factors. I will definitely look at treating the symptoms, at least having something available on an as-needed basis. If it's an acute care situation, or even at home, to have something potentially that could be taken as needed, especially for agitation as well as perceptual disturbances. But the other big piece, and is probably the clinical pearl here, that I've learned with time is that if you can, if it even passes through your mind that this might not be reversible, it's good to communicate with that with the family earlier rather than later. It helps them prepare. It makes them feel that they understand the situation better. And then it will lay the groundwork for more conversations that may come if, in fact, it isn't reversible. If it is reversible and you're wrong and you're able to clear the delirium, then that's bonus time, right? So my preference is usually, if I think it may not be, just to say, of course, we're going to do everything that we can to try and reverse this. But because of the advanced cancer and the toll that the disease is taking on the body, it may not be possible, despite everything we're going to try and do, is usually along the lines of what I will say. And that brings me briefly to talk about opioid neurotoxicity, just in that, anytime we use opioids, there's always the possibility, with no set dose, right? There's no set ceiling, but everyone's metabolically different. And so you don't know what their opioid toxicity level is per se until you actually start dosing the opioid. However, as soon as you see delirium, and especially if you are to see myoclonus, early signs are often vivid dreams, if they volunteer that, or sometimes early hallucinations as well as drowsiness and a bit of confusion. If you start seeing it, sometimes a bit of hydration will be enough, but most usually you're going to run into a situation where the opioid is no longer effective as analgesia and it is causing all these symptoms. And so the treatment of that, of course, we would usually either switch or rotate the opioids. And then consider whether hydration could also be helpful to kind of flush out those metabolites, right? Because we reckon opioid toxicity occurs when either the parent opioid itself, in the case of, say, fentanyl, or a metabolite builds up in the body to that point where it's no longer effective for analgesia, but also causing all these symptoms. And then, of course, because, it often will present as delirium and you don't know for sure if opioid toxicity and or dehydration may be the only things, it may be worth looking at a full delirium workup, depending on goals of care in the situation as well. And again, just as a really quick reminder, because hopefully I'm keeping this as practical as possible, when I go to switch or rotate an opioid, I will generally add up the total daily dose of the opioid, just because there are different regimens. You can be using long-acting, short-acting, Q8 hourly, depending on renal clearance and so forth. It's usually safer, if I'm not doing this all the time every day, to just work with a total daily dose. Then calculate the dose of the new opioid that you're going to switch to using the table I'll show you next. And then you have to account for incomplete cross tolerance by reducing by another 25 to 30%. Most usually I will go closer to 30% for the new opioid. And then with that reduced amount of the new opioid, figure out what your around the clock dosing is going to be. And then lastly, if you want them to have a breakthrough dose, which usually in the setting of advanced cancer you would, then it's always the easiest way to remember it is 10% of total daily dose. Yeah. So, I mean, any of these you can look up as a reminder, and or you can give us a shout if you need, but this is usually what I would go to. And with the equal-analgesic dosing table, I will just say that there are variations of this out there. They're pretty similar, but there is a little bit of variability. I think any of them are good, but this is the one that we use. And of course, every patient's metabolism, every patient is individual, right? So this is generally speaking. So I just wanted to include it here as a reference for you if you need. And then of course, that's the potential contributing factors to delirium, but there's also the management of symptoms. And again, this is where we would generally be looking at neuroleptics. Often a subcutaneous route can be quite practical if possible. And so for that reason, we often are looking at things like olanzapine, haloperidol, loxapine, or even methotrexate in very advanced illness and more acutely worsening symptoms. We would, again, like dyspnea, generally avoid using benzodiazepines because we know they often can precipitate delirium unless we do find that this is an irreversible delirium. And if there's refractory symptoms that are not settling despite all of this, in which case we will definitely add in benzodiazepines once we already know it's irreversible. I would just mention, because we're talking about clinical pearls, that there are some other agents that can be helpful, such as like subcutaneous phenobarbital, but feel free to give us a call if you need help with any of that as well. And again, if we find out that this delirium is irreversible, a lot of it is that conversation. And hopefully if you've had a chance to mention this to the patient's family, then you can then circle back and say, we did the full workup, we've rotated and switched the opioid, we've given fluids, and unfortunately still this is a situation. And so a good time to review goals of care is needed, and certainly adding in and titrating the neuroleptics. And if you need benzodiazepines, usually if we go out an irreversible delirium, especially if it's escalating quickly and the symptoms are escalating quite rapidly, usually time is very short. So at that point, I think to add in a benzodiazepine is often very good to consider. And although you'll see in the literature, especially from our program, that we'll often recommend a midazolam infusion, I find that it's not always that feasible, even in acute care, depending on the situation and the unit and the nursing staff comfort with it. And so I would say anecdotally that I'll often just use intermittent subcutaneous around the clock Ativan instead, and or whatever benzodiazepine that you can easily and safely administer. And that'll is slightly less elegant than an infusion, but also will usually do the trick. So clinical pearls for delirium. It's more likely to be irreversible in advanced cancer. So a good idea, if it passes through your mind that it might be irreversible, to just float that idea with the patient's family. Median of 3 contributors, again, specific to advanced cancer. And then for opioid toxicity, consider rotation and hydration as well as delirium workup. So I just want to talk a little bit about some things that I found helpful for conversations. And then I just had a couple of slides on kind of looking after our own wellness as well. And then hopefully we should have lots of time for Q&A too. I will try my best to answer questions. Okay, so for conversations, these are some of the things that I've just found over the years that I've come across. I really love the Wish, Worry, Wonder framework. It's just such a gentle way to use our words in the English language to bring up things that are maybe not that difficult or not that easy to talk about. So I don't know, for example, I wish we didn't have to have this conversation, but I do worry that you may be as strong as you feel right now, and you may need more and more help over time as you become a bit weaker. So I wonder if we can talk about what supports you may need to have in place or where you may need to be in order to have the supports. Something along that line. You could use it in very many different ways, but I know probably many of you are already using it. I'd come across it and then I heard it again not that long ago and thought, yeah, you know, this is really good. The other piece is that I think in the earlier parts of my practice, I would always worry that someone was in denial if they would talk about things that seemed completely unrealistic to me. But with time, I guess I often recognize that, in fact, they could be talking about their annual vacation to Florida that they plan to book a year from now. And you're thinking, my God, like, probably not going to have a year. What are we talking about this for? And yet often in the same conversation, they may also bring up advanced care planning. Did you know I made a will? So I think that what I would say is that generally we're able to hold two opposing things at once. So it's not necessarily denial. A lot of times it's processing, right? And I think this is human nature, and we will often do it. You hope for something, but you're also prepared for something else. And I think that hope being really important, and it's good for us to align with our patients and hope for the same things they do, but also really prepare them that it may not be the way that they hope, especially with many of the patients that we see that are so ill. You know, and often it's not just one diagnosis, right? It's frailty with multiple comorbidities too. So yeah, I think those are just some of the things. The other one I just wanted to mention, because I came across it a few years back, is the work from Area and Data Labs that they've graciously shared with AHS. Apparently, AHS, we can use it so long as we're letting them know what sessions we're doing, which is amazing. Like, who does that? Anyway, it's a group out of Boston, Dr. Atul Gawande, author of Being Mortal, you've probably heard of him. Anyways, he and some colleagues have developed serious illness conversations. And the reason I mention it is that there are workshops available through AHS, yeah, my learning link. I took one years ago and was a facilitator for a while. But the thing that is really unique about it is that it's patient-tested language, which I've rarely come across. And the other piece is that they have actually studied this more and more over the years, even since they started the program. And you can actually access any of their materials if you sign up on their website and give them your email as well. So just something that I wish I had known earlier. Okay, well, I think as Denise mentioned, I work here in the Office of Advocacy and Wellbeing, and it's more specifically for student support, but I think perhaps because of that role, I think it makes me think a lot too about what are we doing for our own well-being. I think we've talked a lot about the suffering of our patients and their families. And I think that we do recognize that being able to alleviate some of that suffering can be so meaningful, being a part of their journey, hearing their stories, hearing their advice, their experiences. Like, I really honestly find that such a fulfilling thing. And I feel so fortunate that I even have a chance to do any of that. But on the other hand, I also do recognize that being a part and witnessing so much suffering can take a toll on us, and it is an emotional investment. So there's kind of that old saying, right? I mean, anytime we fly, put on your own oxygen mask. But I think that it's true, and it's a good analogy. I think that if we are to help our patients and families in the best way, that we do need to be cognizant of how we are doing and supports we might need, and how, you know, perhaps we need to work on balance a little more from time to time. Certainly, I find for myself. And the other thing I really have tried to be more intentional about in recent years is taking note of those really meaningful, rewarding moments, those conversations that sometimes were a challenging conversation, but it was important and needed to be had. And the tension of the room just went right down after that conversation. You know that it was tough, but it was good. Like, I think remembering those moments and what it meant, because we all know that, you know, there are factors that are easier to control than others, and there are individual skills that we all have, and there are things that I think, you know, most of us are always working on to some extent throughout our practice of medicine. And there are also workplace factors, and certainly many of you may be leaders and perhaps better placed to work on some of these, but we all play a role in our workplace, right? We all work there. And so being able to recognize what are the things that we could be doing a little bit better, just to create that atmosphere for ourselves, look out for each other, support each other, as well as what we can be doing individually. And certainly the CMA, I like some of their resources recently. They tell us to look out for each other. And we know that burnout can be really insidious. And sometimes mentorship, just, you know, checking in with each other, you can make a big difference. And then, yeah, thinking about psychological safety within our teams and what that can mean and what type of environment we want to promote. And just because I'm talking about wellness, you know, just as a reminder for all of us, myself included, that, you know, there are a lot of awesome supports out there, whether through PFSP and the AMA, through the university, through our zone, there's lots of different things and many other, as well as informal supports too. And one last tip just before the Q&A. This is again something I just started doing, I would say maybe 2 years ago. And well, you know, there was the pandemic, right? And it was exhausting. We were all exhausted. And I kind of found like this, I wanted to find more meaning in my work and my clinical work. Sometimes consults, it was just day in, day out, you know, and I would only get to meet patients just one time. And then I remember I went to a presentation by Dr. Harvey Chachanov. He's a psychiatrist out of Winnipeg. And he reminded me of that work that he's done over many, many years in terms of dignity therapy. And dignity therapy itself, tremendous work, but takes a lot of time for the patient, for the psychologist, and for the whole team to transcribe and really work through all the questions and parameters around what is dignity to them, what can enhance their dignity. And so it's truly amazing, but generally I would say often not something that we're resourced for, but he crystallized it down to one question. And that question is something I try to incorporate in my consults now, and that is, what do I need to know about you as a person to give you the best care possible? And I think I just mentioned it because what I found is when I've been able to ask that question, the whole tone of the conversation changes, whether it's with the patient themselves or sometimes if they're not able to participate in this with their family. What is it that I need to know about your mother? Or what is it, you know, I find that it shifts to that person piece. And so you can time it wherever you want in the conversation, but it really shifts to, I want to understand who you are as a person. What's important to you? What do you value? What are your goals as time runs short potentially? You know, there are so many things that you could build on this. And if you get to know them as a person, then you're better placed to make recommendations too, right? So yeah, I mean, it's just one practical tip. And I also just recently found a really beautiful article by Dr. Pam McDermott about using it in a rural hospice in Ontario. So yeah, that's in the Canadian Family Physician if anyone's interested. And that sums up all the pearls that I had meant to talk about today.
Thank you so much, Sarah. We do have some questions. So just everyone who's on the call, reminder, the Q&A box on the bottom of your screen, please pop in there and add questions for Sarah. So Aurora is asking a couple questions. Sarah, I just wants you to talk about TENS, like what is TENS, and also maybe perhaps how that works for pain. And then was asking about anxiety agents specifically. We could give some examples of agents that you use.
Sure. Just practical question. Should I stop my screen share?
Oh, probably good. Yeah.
Okay.
For now. And then I think there's just also tip to everyone. We will put a little thing in the chat and in the screen around evaluation. So value your feedback. So please do that when it comes on. So thanks.
Okay, well, that is an excellent question, Aurora. And I'm sitting here thinking, what exactly does an acronym stand for again? Being honest. So TENS, like a TENS machine, it's like trans something electrical nerve stimulation, something like that. Being honest.
Transcutaneous electrical nerve.
Transcutaneous, thank you. What I can tell you is our colleagues in physiotherapy, this is often their area of expertise. So I would recommend or talk to my nearest physiotherapist about this. I have had patients with very challenging pain syndrome because it's not non-pharmacologic, right? And because it's something physical, it's something they can see, it's something they have control over potentially. I've even had patients buy their own TENS machine and find it really helpful. And I'm kind of of the mind like, hey, if it helps and it's not hurting, it's helpful, great. So recommend that if people are interested, but it would be our physiotherapy colleagues. And thank you, Denise, for saving me on that acronym. Oh,
no problem. The second part of that was just a little bit more discussion about anxiety agents you use.
Oh, yes.
Benzos.
Yeah, so with the neuroleptics, okay, so what I would generally think about for this one, it depends a little bit on availability, right? And also how much or how quickly you think you're going to need to titrate them. If you've got a longer time frame and there's a lot of layers to this, a lot of psychological suffering, perhaps maybe substance use disorder, like lots of different things, I personally find Seroquel quite helpful because there's a very broad range. You can start with very, very low doses, only at HS if you want to, and you can titrate it to hundreds of milligrams a day, according to our psychiatrist colleagues. Not necessarily saying that you need to do that, but it gives you a lot of range and scope. Now it's only available PO, so for our very acutely ill, hospitalized, end-stage patients, it's not going to be much help. So in that situation, olanzapine's nice, but again, it's tricky to get subcutaneously. So if a patient who's bedbound, having difficulty swallowing, I'll often still go with haloperidol. Or if that's not effective or not available, loxapine. And again, if it's very, very advanced and then none of those are really working, methotrexate is pretty nice too. Does that help?
Will Aurora, that just pop into the Q&A if it doesn't totally answer your question. But we'll go to Hilda. So Hilda has a couple of questions. So first, with regards to dyspnea, can you please review the etiologies where you would use steroids for dyspnea versus etiologies where you'd consider oxygen? And then the second part of her question is there any role for pulse oximetry in dyspneic patients?
Excellent questions. Thank you. Yes, I think the line that I had about dyspnea, I had said sort of oxygen / steroids. And I apologize, it wasn't necessarily meant to be an either or in that situation. I just was thinking about them both at the same time. So sorry with that wasn't super clear. In terms of oxygen use, I think, again, the etiology is a piece that I really try and think about for any of our patients with malignancy. Usually we know that oxygen isn't necessarily going to change their SATs, but if it helps with airflow, if you can get it for them. The tricky part is, especially in the community, getting them approved for home oxygen, right? Whereas our patients, for example, with ALS, this is hypercapnic respiratory failure, so I want to try and avoid oxygen. Patients with interstitial lung disease that can often need 10, 15 per hour, liters per minute. So there's a lot of variability with oxygen, but I think like whether you're using it, I often like to think about it like a medication. In that it makes me very intentional about what type of respiratory impairment is this, and is it going to work, or how am I going to monitor that? And then also practically speaking, like I say, whether or not it gets approved for home oxygen is often a practical consideration as well. For steroids, other than our patients with COPD exacerbations and so forth, I would say a lot of times steroids are something that I think about for our patients with malignancy. And I think sort of the way I think about malignancy, there's like the symptom can be caused obviously by where the tumor is, but also any of the sequelae of it, right? Like maybe there's some lymphogenic carcinomatosis, or, there might be some bronchial obstruction, but all of those things can potentially respond to that reduction of inflammation with corticosteroids. So that malignancy is often where I think about it. Pulse oximetry, amazing question. Yes. Because it's so subjective, dyspnea, it isn't always helpful. Like I think at first it's good to know. And if certainly if you're going to be titrating the oxygen, then you're going to need that. But definitely by the time patients are more in stage, when the goal is comfort, I'll often actually remove it at that point, because otherwise patients and families perseverate on it and watch the numbers, and it becomes, first of all, less accurate as the circulation and perfusion worsens, but also, and heightens their anxiety, but also it is going to change it. It's going to get worse in the very, very end stage. So I would take it off at that point. If that comes.
Thanks. So Aurora says, yes, you answered her question. And Fazia has a couple questions here. So the first is regarding serious illness conversation. Is there any way for registering for physicians who don't have My Learning Link? As unfortunately, many of us in primary care are outside of AHS. And the second part is, does Suboxone work for dyspnea?
Oh, okay. You know what? I'm really sorry. I didn't realize that My Learning Link wasn't all that accessible. I apologize.
Well, fortunately, we have the Office of Lifelong Learning. So Andrea, can you take a note of that? Because this looks like something that could be super useful. So maybe we should follow up and see if there's some ways to promote this outside of My Lifelong Learning Link. So thanks, Fazia, for flagging that. It's really important.
Sure, we have tried to do that with other courses, like, there's one in heart disease from My Learning Link that we talk to AHS, and we have access for everyone in our website. So I'll talk to Sarah and see where we can.
That's awesome. Thanks, Andrea. And then Fazia's follow-on question is, does Suboxone work for dyspnea?
You know what? This is where I wish my colleague who's presenting in 2 weeks from now was on. Because my colleagues at the Cross Cancer Institute, because they see patients who are much earlier on the disease trajectory than many of us do, we tend to see more advanced illness. They use Suboxone more than I do. They use it, though, I would say primarily for pain. I'm not aware that they're using it for dyspnea, and I personally am not using it for, I haven't used it for dyspnea, but it doesn't mean it doesn't work. So I guess the answer for that would be, I'm sorry, I really don't know the answer.
No, it's fine. Thanks. It's always good when we don't know. Actually, well, I've got a little follow-on for that too. So this is a million years ago, but what is the role of morphine for dyspnea in terms of back, and this is probably 100 years ago, but there was sort of this thought of, increasing some of the, what was the mechanism of that? I don't even remember, but I have seen it used. Do we ever use low-dose opioids for dyspnea?
Absolutely, yeah. And I think especially subcutaneous, like especially if it's really end stage, because it's hard to swallow a pill when you're short of breath, so earlier on for sure. But I agree with you, especially end stage dyspnea of any etiology, low dose opioids. Now, Denise, what I think I remember, and possibly you remember too, they were even talking about nebulized opioids at one point, but unfortunately, the data didn't really bear that out as a good option.
Yeah. This is scratching in the back of my brain. I had a question for you too. You mentioned about trauma-informed care, and we hear that term a lot. But what does that mean to you in the work you do in palliative care? What does that mean? How do you practically think through providing trauma-informed care?
I love that question. I'd be happy to do a whole talk on that. I'm truly, because I'm still learning. But when I think trauma, I think in this context, I'm thinking psychological trauma. And I think whether that be, we talk about from, depending on the time of life in which you went through that trauma, or possibly it was something in childhood even, you grew up in a place that was unsafe, it's hard to come back from that. You can, right? And you can heal. But I think if you've experienced trauma, psychological trauma, where you feel as though your life or your safety may be at stake, whether or not it actually was, that's how you felt in that moment, whether you witnessed something, experienced something. So some of the more common ones, I guess, would be, other than certainly childhood abuse, for example, or sexual assault, or witnessing a violent accident, or natural disasters. Like there are a lot of different ways in which we can experience trauma. There's even that concept of vicarious trauma for those of us in healthcare. But it's very individual, and we have protective mechanisms, some more than others, and so it all affects us in different ways. But the way I look at it is not that I need to know whether someone has experienced trauma. Sometimes I could take a pretty good guess, right? But I don't always know, and you don't want to trigger and re-traumatize them by asking at the wrong moment, especially if you don't have that rapport. So the biggest thing for me is like I kind of always have it on my radar. And if I feel like someone's holding back, if I feel like they're reserved, if I feel like they're not trusting me, they don't want to take my advice, and there's a barrier there, then there's a part of me that kind of just sort of assumes it could be past trauma and that it's not specific to me, but I have to work extra hard to earn that trust now, right? And kind of figure out like, how do I do this? How do I empower them to feel like there's options, there's choice, and I'm here for them and they can trust me? So that's kind of where it comes from for me. It's just always in the back of my mind a little bit, even if I never know whether or not someone for sure has experienced that or whether it needed to be part of their care or not.
Okay, and then following on from that, I mean, maybe the process of dying in palliative care is one of the most traumatic things someone's actually experiencing, and their families. So with that sort of thought, what are the things that you do in your practice to try to recognize that this is all new potentially for them, and scary and nasty and horrible, and for their families, especially if they have young families? And how do you help reduce and mitigate that trauma that they're actually feeling like right now?
Yeah, I think that is very fair. And we certainly, although because of the nature of that field, we don't always have all the data on how traumatic it was for folks. We know if an intensive care stay, depending on the person, can be traumatic, so we have data that medical intervention, including potentially palliative care, can be traumatic. What I always think about is, what were the past experiences? Because that'll often color what's happening now, and how they feel about death in this instance is often impacted by prior experience. And as you say, sometimes there is no prior experience, and this is completely uncharted. And for each one of us, one day when we're patients, it will be uncharted territory. And so the way in which we think about that and approach it can be so unique and not necessarily predictable for any one of us. So I think kind of that idea about this needs to go well, not just for the patient, but for their entire support system and family, for their lives going forward, for the way in which they remember how this went. Because you do hear about people saying like, oh, well, my aunt suffered horribly. Probably it was agitated delirium rather than pain, but in any event, what they took from that is this was terrible pain control and they really suffered. And so I think we see the impact of death and the dying experience and how that impacts people that do survive that from the family and from the support system. And then for the patients themselves, I mean, I think it's just sort of walking alongside them and try and take your cues from them, like try and share the information that you have. Like I think one thing with serious illness conversations is that they really prompt us to share prognosis when patients are, willing to talk about what may be next. And I think that that's something that we often are loath to do because we don't want to be wrong, but it can be really empowering knowledge for patients and families. But then you also have to gauge, like, is it time for that? Is that the appropriate conversation, and not rush in there and trying to foist our ideas on folks? Yeah, I don't know if that helps, but it's tricky. It's tricky. It's a really, really difficult time for our patients and their families.
Well, thank you so much, Sarah. It's such a great session. So folks, there's a little QR code on the screen for feedback. This is the first 3, but we are committed to carrying on with this conversation beyond these 3. So please also reach out if you've got additional things, that supports you need, topics you want, resources, etc. We will look into that course, and looking forward to seeing folks for the next session, which is going to be on October 1st with Ingrid de Kock, on how do I enhance support for my patients with advanced disease who wish to try to remain and perhaps die at home. So that'll be a really great session. And then the last session is on October 8th with Dr. Chabasal around